For a case of hematuria, using our mnemonic old cards, we'll note the onset, or when did it start. For the duration, we want to know if the hematuria is occurring constantly with every urination, and within those urinations, is the hematuria seen constantly throughout the entire urinary stream, or initially or terminally at the end of the stream? Or is the hematuria only seen intermittently? And if that's the case, we'd like to note the frequency, or the number of urinations that we've seen hematuria. And within those urinations, is the hematuria seen constantly throughout the entire stream, or initially or terminally at the end of the stream? Next, we can note the progression. Does the hematuria appear to be occurring more frequently or more severely? Or if there is no progression, we'd be sure to include that in our patient note to show that we asked. To characterize the hematuria, since it is a bodily fluid, we'll use our mnemonic A, B, and C to write down for our patient note the amount, blood, and color. And since this is a urinary case, we can ask now or later in our review of symptoms of other urinary signs, such as straining, polyuria, dysuria, or urethral discharge, among others, as we'll see below. Aggravating and alleviating factors if there is pain, radiation, treatment, and severity on a scale of 1 to 10 if we have dysuria. Or if there are none aggravating or alleviating factors or radiation, we'll also be sure to state that in our patient note to show that we asked. To help break down a case of hematuria, we'll visualize the urinary system into its component parts: renal, ureter, bladder, and urethra. For all cases, we'll order a genital exam, rectal exam, CBC, serum electrolytes, BUN creatinine, PT, and PTT as we do for any case that involves blood, urinalysis, a urine culture, and an ultrasound of the renal system and bladder. In pyelonephritis, or an upper UTI, our supporting points include hematuria, abdominal or flank pain, polyuria, dysuria, fever, nausea, and vomiting, and if we have any vomiting, we'll be sure to use our mnemonic A, B, and C to write down the amount, if there's any blood, and the color of the vomitus, and as we'll see in our physical exam coming up, the positive special test for Cva Tenderness, and we'll add to our workup a CT of the abdomen and pelvis. In glomerulonephritis, we'll see hematuria, edema, hypertension noted on the vital signs, and a history of a recent URI or gastrointestinal infection. And we'll add a CT of the abdomen and pelvis and a renal biopsy. In polycystic kidney disease, we'll see hematuria, abdominal or flank pain, polyuria due to the concentrating defect, again a history of hypertension noted on the vital signs, and a history of UTIs such as past episodes of dysuria. Also a family history and positive Cva Tenderness. We'll add a CT of the abdomen and pelvis. In renal cell carcinoma, classically we'll see the triad of hematuria, abdominal or flank pain, and a palpable mass. We'll also see the characteristic weight loss or decrease in appetite seen in cancers, and positive Cva Tenderness. We'll order a CT of the abdomen and pelvis and a renal biopsy. In nephrolithiasis or urolithiasis, all ways of writing the same differential, we'll see hematuria, flank pain with the characteristic writhing as we'll see coming up, polyuria, dysuria, straining, a weak stream, dribbling, and pain radiating to the groin, and positive Cva Tenderness. We'll add a CT of the abdomen and pelvis. In cystitis or lower UTI, we'll see hematuria, lower abdominal pain, polyuria, dysuria, and now positive suprapubic tenderness, and we'll add a CT of the abdomen and pelvis. In a bladder cancer, we'll see hematuria, straining, a weak stream, dribbling, the characteristic weight loss or decrease in appetite seen in cancers, and our patient will have a history of heavy smoking or occupational exposure as a painter, and we'll see suprapubic fullness. We'll add a CT of the abdomen and pelvis, urine cytology, and cytoscopy. In benign prostatic hyperplasia, not hypertrophy, and we'll use the P in prostatic to help remind us of the plasia, we'll see hematuria, polyuria, nocturia, straining, a weak stream, and dribbling, and we'll add to our workup a PSA and an ultrasound of the prostate. In prostate cancer, our supporting points will see are hematuria, polyuria, nocturia, straining, a weak stream, dribbling, now new onset low back pain, and the characteristic weight loss or decrease in appetite seen in cancers. We'll add a PSA, an ultrasound of the prostate, and a new prostate biopsy. In prostatitis, we'll see hematuria, polyuria, dysuria, straining, a weak stream, dribbling, and now new onset pain on ejaculation, fever, and a history of anal intercourse. We'll add a PSA and a nucleic acid amplification test for gonorrhea, chlamydia, and an HIV antibody. In urethritis, we'll see hematuria, polyuria, dysuria, a new urethral discharge, and a history of sexual contacts. We'll add a gonorrhea and chlamydia test, an HIV antibody, and a culture for any urethral discharge. And finally, in a urethral stricture, we'll see hematuria, polyuria, dysuria, straining, a weak stream, dribbling, and a history of urinary procedures. We'll order an ultrasound of the urethra and a cytoscopy.
In this case, I'm going to be dealing with or showing you how to deal with a patient with severe pain. The pain could be abdominal, it could be head, it could be anywhere, but in this case, it's going to be abdominal pain, okay? So I'm in the emergency room, and I'm talking to a patient with severe abdominal pain. How long have you had this?
I can't even stop moving. It just keeps coming over everywhere. I can't even
I'm so sorry.
Answer your questions.
I'm so sorry.
Painful.
You know what? I'm going to do you a real solid, okay? I'm going to quickly take this history, take a very quick physical examination and get you relief you need.
You can't just give me medicine or something right now?
I can't give you medicine until I know what's happening or at least have an idea, but I'm just going to be as quick as I can, okay?
Thank you.
And get you the relief you need, okay?
Much.
All right. So that is how you deal with a patient in the ER who has severe abdominal pain.
Okay, we'll start our abdominal exam with a hand sanitizer, and we want to ask our SP if we have permission to examine you while he's still sitting up to the cardio exam to get that out of the way. So the best way to do this here is, again, to lower the gown slightly and to ask them to please sit and hold it like this. This will protect them and keep them covered up. We want to verbalize that we don't see any visible lesions in the anterior chest, no visible lesions to the posterior chest. And we'll go ahead and palpate and see if he has any chest tenderness. So please let me know any pain. Do the same thing on the back. The next thing we can do is auscultate for his heart sound, and so we'll use the mnemonic compartment M225A, and we'll listen first in his right intercostal for the aortic, and we'll go over to the left for the pulmonic, and then we'll go to listen to the tricuspid. And now for mitral, if this was a female, a good tip is to ask him to please lift up your left breast. Comment that we hear an audible S1, S2, regular rate and rhythm, no audible S3s, S4s, or murmurs, rubs, and gallops. Once we completed the cardio, we could transition nicely to the home exam while he's still sitting up, and so we could go ahead and percuss. We'll start above his clavicle, comparing left to right. And we're going to go ahead and do the same thing on the back, 3 spots. Auscultate again, and we'll start above the clavicle. We're going to use the bell first. Please take it, and the instructions you want to give is please take a deep breath when you feel my stethoscope. Please take a deep breath in and out. Okay, compare left to right. Do the same thing on the back now. Okay, then we could verbalize again that it was clear to auscultation, no audible wheezing. Once we concluded the cardio and pulm exam, we could cover him up again. Now we can instruct him, I'm going to now lie you down to do the abdominal exam, is that all right? Okay, so we want to help them down. And you don't want to forget to extend the legs for the leg rest. Now you could rest your legs. For the abdominal exam, they'll have a gown here, and you want to move it up all the way to their pelvis, and then you want to ask permission to take it up. We want to do the same step again. We want to first verbalize that we see no visible lesions. First, ask if he has any pain anywhere.
Yeah, just right here.
A little pain on the upper right side. Okay, so now we're going to go ahead and start on the opposite side on the lower left. So, okay. Go to the right. Okay, we could verbalize that there were normal active bowel sounds. He had pain on the upper right. We'll start on the lower left.
normal resonance to percussion. Now we're going to go ahead and palpate. So the tip for this is for superficial first. We're just going to use one hand, and we're going to start in the lower left. And you want to make good eye contact to see if he winces at all, or let him know if you have any pain.
If we're concerned for cystitis, we would want to assess suprapubic tenderness. And so we will expose the area and we'll assess his suprapubic area over here by palpating. And if he has pain, he'll let us know. Do you have any pain?
Yes.
Okay, so now we would be concerned for cystitis.
3 quadrants on the bottom, 3 middle quadrants, and then 3 upper quadrants. Okay, and then we could have good confirmation that he was in pain. Now for deep, we just want to place our second hand on top and do it again. Okay, so we could get a little pain there on deep. But once we complete a deep palpation, we want to go ahead and check for hepatomegaly. So the best way to do this is to place your hand under the border of his liver. You want to instruct the patient to please breathe in. And then as he breathes out, you can breathe out now. You want to go all the way up into the lower rib cage, and as long as you don't feel the liver extending below, you can verbalize that there was no hepatomegaly, and you can do the same thing for the spleen. So again, please breathe in, and now please breathe out. Okay, and you can feel the lower left rib, and there was no spleen coming down.
Okay, and very important for a case of lower abdominal pain, if we're concerned of nephrolithiasis or pyelonephritis, to check for kidney pathology, we're going to assess Cva tenderness. So to do this, we very simply make a fist, and we could ask them if they have any pain when they tap. We'll do left. Do you have any pain here?
No.
Okay, and then we'll assess the right as well. Do you have any pain there?
Yes, I feel.
So now he has positive, we're concerned for renal pathology on his right side.